This is our cardio case study presentation, status post-hip fracture. Our patient is in for status post-hip fracture and an upper respiratory infection along with shortness of breath at rest.
The patient presents with a past medical history of stage 2 hypertension, chronic AFib, and smoked 1 pack per day for 60 years. Her stage 2 hypertension may cause her to experience shortness of breath and arrhythmias, and it's possible that smoking influenced this onset. Her AFib is potentially also due to her hypertension, so she may experience heart palpitations, decreased exercise tolerance, shortness of breath, some lightheadedness, dizziness, chest pain, or weakness. She is also at an increased risk for the development of COPD due to her smoking 1 pack per day for 60 years. On intake, she was taking about 4 medications. Digoxin is for heart failure and abnormal rhythms. Vasotec is an ACE inhibitor used to treat hypertension in regards to heart failure. Catapres is also used for hypertension, and Isordil is prescribed for the management of angina and coronary artery disease. Vital signs suggested that she is tachycardic, which may also cause her shortness of breath, dizziness, chest pain, or a lightheaded feeling. Her blood pressure is conclusive of her stage 2 hypertension, but suggests that her medications are poorly managing it. She has a rapid respiration rate that indicates potentially short, shallow breaths similar to tachypnea associated with her respiratory infection. She also has a fever and may experience increased sweating in order to cool down her body. She appears mildly obese and in marked distress, which may lead to decreased energy expenditure and an increased work for activity. This may also increase her shortness of breath due to the decrease of diaphragmatic excursion from excess adipose tissue. The patient's jugular vein distension is suggestive of acute heart failure, which may also cause her shortness of breath, pitting edema, and decreased lower extremity strength. She presents with a decreased breath sounds and inspiratory crackles at 2/3 of both lungs. She's dulled a percussion at the right distal base, which indicates the potential for a right pleural effusion, which was confirmed by a chest x-ray later that day. This may also correspond with her respiratory infection and potential risk for pneumonia development due to involving movement of air through secretions and potential increase in fluid throughout the lungs. This leads to shallow breathing, shortness of breath, and potential upper chest pattern breathing. Her heart rhythm is irregular with an increased P2 sound and systolic murmur, which is indicative of pulmonary hypertension and pulmonic valve closure insufficiency. This coexists with heart failure and cardiomyopathy, and she has a left parasternal lift, which is caused by left ventricular hypertrophy. This is most likely secondary to her uncontrolled hypertension over the years, putting an increased stress on the left ventricle. Her S3 heart sound often accompanies jugular vein distension and indicates congestive heart failure with a non-compliant left ventricle. Her liver is palpable through her abdomen 3 centimeters below the costal margins, and her right pleural effusion may be leading to lowering of the liver boundaries, which also includes diaphragmatic flattening, affecting her respiration and ventilation. Lastly, she presents with 2+ pitting edema, as expected with acute congestive heart failure, indicating impaired circulatory flow and venous insufficiency. The patient may complain of heavy legs and weakness at this time.
The patient had a number of diagnostic testing done. The electrocardiogram showed atrial fibrillation, a ventricular rate of approximately 110 beats per minute, which is considered sinus tachycardia, left atrial enlargement, which could be due to the chronic atrial fibrillation, left ventricular hypertrophy with strain patterns. This can then cause the muscle wall thickness to increase and sometimes the size of the chambers. Poor R wave progression, which can be indicative of an anterior MI, but it is not a diagnostic tool. The chest x-ray showed marked cardiomegaly, which is just enlargement of the heart, a small right pleural effusion due to buildup of fluid, moderate pulmonary congestion, which is typically seen due to some sort of pulmonary edema or excess fluid in the lungs. The echocardiogram showed an increase in all chamber values and a decrease in ejection fraction. And ejection fraction is the best indicator for cardiac function. And since it is not preserved in this patient, it indicates that she has systolic heart failure. A number of lab values were also elevated. Glucose, which could be indicative of diabetes. Potassium, which is important for normal function of the heart. If the patient is diabetic, she could be at risk for diabetic ketoacidosis. Uric acid, which can be a result of her taking the diuretic, lactic acid dehydrogenase, which indicates tissue damage, and digoxin, which shows whether or not a medication is working. Side effects are vomiting, dizziness, changes in heartbeat, and confusion if the levels are too high.
For our PT techniques, we would first do heart and lung auscultations. They did these in the case study, but we would do them again based on her medical history and to see if there are any changes. We would do heart auscultations because she has CHF and to see if an S3 sound is present. We would also do lung auscultations because she has a history of smoking, symptoms of upper respiratory infection, increased shortness of breath, and also chest x-ray findings of pleural effusion and pulmonary congestion. We would do a cough assessment due to the upper respiratory infection and the chest x-ray findings. This eventually can become an intervention for proper airway clearance for her. We can then do hip range of motion and MMT. We can do this in supine, and the patient will be asked to lift her legs as best as she can to see her overall strength and also get her range of motion. This will be a way to assess if she's capable of transfers with either min or mod assist. This can eventually become a progression to ambulation too. We would do the W technique as a screen to look at her lung excursion. We would look at her normal breathing pattern first and also her thoracic expansion, especially due to the shortness of breath and the infection symptoms. We could then do a tug with an assistive device for the hip to assess her fall risk, especially because she had a previous history of falls.
So the first cardiopulmonary impairment is the impaired cardiovascular pump, which she likely has because she has AFib and the chronic heart failure. She has impaired circulation because she does have pitting edema of 2+, as well as the doctor noted that her skin was cold and pale. She has impaired respiration, impaired ventilation, likely due to the smoking history, so her lungs aren't able to inflate as much as we would wish. Impaired aerobic endurance. It's likely that this patient had a sedentary lifestyle before coming to the hospital, and it's only going to get worse due to the period of immobilization following surgery. So it's going to decrease even more than it was before. And then I would suspect that she has an impaired cough, which caused the upper respiratory infection that she came in with. Because she's not able to clear that mucus, then everything's going to get stuck and cause an infection. Then for other associated impairments, this section I focused more on what she's going to deal with following the hip repair. So she did get an ORIF on her hip. So she's going to have impaired strength since she's going to be weight bearing as tolerated with some sort of assisted device, I suspect a walker, due to her not being able to put all the weight through it and then do things like she probably did at home, such as like stairs and going in the public and doing ADLs. Her strength is going to decrease. Her posture is likely impaired because most people do have the forward posture. The walker is also going to facilitate this. She's going to lean over like a lot of people do, and that's just going to contribute to that. Gait dysfunction and impaired balance. Once again, I got to go to the assisted device and this ORIF, and she is walking in a different way now. And impaired balance, she did fall before she came to the hospital, so her balance is going to be even worse now that she has to relearn how to walk.
The patient goals for rehab, based upon the examination techniques and interventions that will be performed, include her short-term goals will be in 3 weeks, the patient will demonstrate a decreased tug score by 5 seconds in order to decrease risk for falls. In 3 weeks, the patient will demonstrate the ability to safely get on and off the toilet with minimal assist. The patient's long-term goal, in 6 weeks, the patient will demonstrate an increase in strength of the right hip flexors by 1 grade with improved symmetry with transitional movements and stance. Due to the patient's comorbidities and recent ORIF of the right hip and respiratory infection, the patient's return to baseline is expected to be slow due to her compromised pulmonary, cardiovascular, and musculoskeletal status. The patient has good rehab potential to return to independent living with skilled physical therapy intervention. The patient is agreeable to physical therapy 1 to 3 times a week in order to achieve functional goals and the highest level of functional independence.
So now we move on to the comprehensive intervention plan for this patient. As always, we want to start by screening vital signs before initiation of treatment, during and after treatment, and we want to be conscious of possible orthostatic hypotension due to the other comorbidities that this patient has. We also want to be conscious of signs and symptoms of exacerbation during exercise. This could include abnormal breathing patterns, shortness of breath, fatigue, sweating, loss of consciousness, any increased hip pain, things like that. And we want to assess the target heart range for this patient using the rate of perceived exertion scale, and we want to track this throughout exercise. So going on to posture. Posture is important to promote optimal breathing pattern with gas exchange, ventilation, airway clearance, and chest wall flexibility. So anterior pelvic tilt and erect shoulders could assist with this. Also looking at breathing patterns, so encouraging diaphragmatic breathing and using re-education if needed, ventilatory muscle training for expiration and inspiration, and pursed lip breathing as well. Stretching would be important for those pectoral muscles and also hamstrings on the contralateral side of the hip, but eventually when precautions allow this, do the surgical side as well. We want to strengthen the scapular retractors and also allow for some distal lower extremity mobility, including ankle pumps, knee flexion, and we also want to be able to eventually work up to step-ups, squats, leg raises, calf raises, curls, and rows also. This will help with posture. And aerobic exercise, so we could start just by doing some seating marching, work up to standing, marching, and steps, and implement a walking program, and gait training would be important as well, and possibly with an assistive device at first, most likely a walker at this point. Okay, continuing the comprehensive intervention plan, we'll do airway clearance techniques using vibration, percussion, improving cough mechanics based on the cough assessment. We want to really focus on functional training in order to get this patient to eventually be independent, so transfer training, so bed mobility, sit to stands, things like that. Also ADL training, so this person is able to take care of themselves. Self-management, including energy conservation techniques, and also refer them possibly to yoga or Tai Chi because it's been shown to improve balance, strength, flexibility, helping control blood pressure, respiration rate, heart rate, and exercise capacity. And overall, we want to educate our patient for any lifestyle changes that maybe need to be implemented, including the importance of daily aerobic activity, including walking, and any other home exercise program exercises that we will give them that we just talked about. And we could implement some more things based on future testing that patient might be able to tolerate, including the 6-minute walk test and or the Bruce protocol, since those are the gold standards for exercise tests. Next, we have our discharge recommendations. So we all agree that subacute rehabilitation would be possible for this patient. We think she has good potential to return home. There are some positives and negatives, however. The negatives being her multiple comorbidities, the fact that she lives alone, her lifestyle tendencies, smoking, lack of confidence and independence level. But also she has some positives, including before admitted to the hospital, she had previous independence. She has a lot of friend support and motivation in order to become independent. So we believe she'll be able to tolerate subacute rehabilitation.
Based upon the case presented, the ICF model includes the health condition, which is a right hip fracture, congestive heart failure, and an upper respiratory infection. The body structures affected include the musculoskeletal system, which includes right lower extremity weakness and range of motion loss secondary to a right hip fracture, the pulmonary system, which includes impaired respiration and ventilation, as well as shortness of breath. The cardiovascular system, due to having a history of atrial fibrillation, congestive heart failure, and decreased cardiac output. The activity facilitators include the PT requires moderate assist to go from the bed to the bathroom. The activity limitations include the inability to complete a 5-time sit to stand due to right lower extremity weakness, shortness of breath, and decreased endurance. Participation. The activities include the ability to ambulate around the mall and grocery store with the use of an assisted device, which includes a scooter. Participation restrictions include the inability to walk around the mall with her friends, the inability to go to church or the grocery store, and the inability to drive. Environmental. The internal factors include positive, motivated to return to prior level of functional independence and return to her weekly shopping trips with her friends. The negative factors include a smoker for 60 years, non-weight bearing on the right lower extremity, and mildly obese. The external environmental factors include positive, friends live nearby and are willing to assist her when she returns home, and the negative is that she lives alone, is widowed, and has no children.
My name is Maria, I'm from physical therapy, and this is Candace. She's an aide, she's going to be helping us out today. Since we took your vital signs, what I want to do is kind of just go over some breathing patterns and try and maybe fix your posture a little bit. Okay? Ready to do that? Good job. Work on some breathing techniques. Alright, I'm just going to leave you there for a couple seconds just to make sure you're feeling okay in that position. So what I'm going to have you do is you're going to look down when you exhale. Good. And you're gonna look up and inhale. We're gonna do this thing called chest PT. Okay, so I'm just gonna be hitting you kind of like this. It shouldn't be painful or anything, but you should feel some pressure. We're gonna try and get those secretions up, and we're gonna break them up so we can try and clear them out of your airways. So we're gonna do this for 3 minutes. How you feeling?
Okay.
All right. We're going to get you up and moving. Try to do some weight shifts just to get used to putting some pressure on that leg, okay?
Okay.
Now push up from the bed with your hand. Just kind of get up, okay? 1, 2, 3. Good. Okay? How you feeling?
Short of breath.
Short of breath? All right. How about that'll be it for today. So that's all we're gonna do for today. But for next time, we're gonna walk. So Candace is gonna grab the wheelchair and she's gonna follow you behind, just in case you need to sit down, okay? All right, so we're gonna walk this way.
Can't wait to walk around the mall.
Good. You did really well.
It's better than yesterday.
Yeah, definitely. So next session, we're just gonna keep progressing every time. We're gonna walk farther and just see how you're feeling.